Good afternoon, everyone, and greetings from Atlanta, Georgia. We want to welcome you to our 2020 Public Health Ethics Forum, Ethical Dilemmas in Rural Health, co-sponsored by the Office of Minority Health and Health Equity and the National Center for Bioethics and Research in Healthcare at Tuskegee University in Alabama. I'm Craig Wilkins, Senior Advisor within the office, and I'll be serving as your Master of Ceremonies. It's a distinct honor to welcome each of our special guests, our speakers, and each of you for joining us today via Zoom. I had the pleasure of being part of a small planning committee that put this forum together. My sincere appreciation and gratitude is extended to them for all their hard efforts in the planning of this year's event. Their names are noted here as you see. I don't have time to mention everyone's name, but again, we wouldn't be here today without all of their planning for this year's forum. So again, on behalf of this committee and our office and Tuskegee University, we appreciate your attendance and participation. Today's forum, before today's forum and with a couple of housekeeping updates, we know today is a very special day and we want to pay homage on this special day of 9/11 and would like to have a few seconds of silence. Thank you. For those of you who want to send in questions for today's forum during the question and answer portions, please send those questions for the speakers via the Zoom Q&A box. If you're having any technical support related questions via the Zoom, please send those also to the Q&A box, or you can also email Kevin Owens, as noted, at nn06@cdc.gov. We also will have a forum evaluation. After the forum, the evaluation will be displayed when you exit the Zoom webinar. And on behalf of the planning committee, we really value your feedback to help us plan for future forums, and your responses will be completely anonymous. We have a continuing education disclosure statement that I will not read, but we are asked to share with you as part of our continuing education requirements. You will note to receive continuing education, the instructions will be available at this link as noted. The activity code for those who watch this event live stream, you will note also the access code. Also the activity code for those who watch the archive event recording, no access code will be needed. And there will be no fees for CDC's continuing education activities. Now, it gives me a great honor and privilege to introduce our opening welcome and opening remarks. We have Dr. Leandris Liburd. Dr. Liburd currently serves as the Associate Director for Minority Health and Health Equity for CDC ATSDR. In this capacity, she leads and supports a wide range of critical function in the agency's work in minority health and health equity, women's health and diversity and inclusion management. She also plays a critical leadership role in determining the agency's vision for health equity, ensuring a rigorous and evidence-based approach to the practice of health equity, and promoting the ethical practice of public health in vulnerable populations. During the COVID-19 pandemic and CDC's response, Dr. Liburd has been part of that response in serving as Chief Health Equity Officer, where in this role, she has been working to advance health equity as a priority across the entire COVID-19 response, and leads a team responsible for developing a data-driven strategy that will address all too persistent health disparities. Our second presenter for opening remarks will be Dr. Ann Schuchat. Dr. Schuchat currently serves as the Principal Deputy Director of CDC. She has been CDC's Principal Deputy Director since September 2015. She served as Acting CDC Director from January through July 2017 and February-March of 2018. She also served as Director of CDC's National Center for Immunization and Respiratory Diseases from 2006 and 2015, and Chief of the Respiratory Disease Branch from 1998 to 2005. She first came on board at CDC as a EIS officer. After completing 30 years of service in 2018, Dr. Schuchat retired from the Commissioned Corps of the United States Public Health Service with the rank of Rear Admiral. And our third speaker this afternoon to provide welcome and opening remarks is Dr. Rueben Warren. Dr. Rueben Warren has a faculty appointment as a professor of bioethics with joint appointments in the Graduate Public Health Program, College of Veterinary Medicine, and Division of Philosophy, College of Arts and Sciences at Tuskegee University. He also currently serves as Director of the National Center for Bioethics and Research in Healthcare at Tuskegee University. He also holds adjunct academic appointments, including the following: as a clinical professor within the Department of Community Health Preventive Medicine, Morehouse School of Medicine, and adjunct professor at the Department of Dental Public Health School of Dentistry, adjunct professor, School of Graduate Studies and Research, the Meharry Medical College in Nashville, Tennessee. And Dr. Warren also served as our first Associate Director for Minority Health here at CDC. So again, the great pleasure to introduce Dr. Liburd.
Thank you, Craig, and good afternoon, everyone. And I bring you greetings today from the Emergency Operations Center here at the Centers for Disease Control and Prevention in Atlanta. And I want to welcome you to our 6th annual Public Health Ethics Forum that we are pleased and honored to co-host with Tuskegee University. We are so excited about today's forum, about our speakers, and the participation of so many people from all across the country. This year's forum would not be possible, as you've already heard, without the leadership of our planning committee. And if we were together in person, I would have every member of the planning committee stand and receive a big round of applause. You saw the names of the planning committee members, but I do want to acknowledge the dedication and the leadership of Craig Wilkins, who I call Captain Wilkins, Dr. David Hodge, and Dr. Rueben Warren. This year, we turn our attention to rural health and how we can achieve an ethical practice of public health in rural communities across the country. Rural communities can represent the best of our nation in the beauty of the landscape, the social connectedness that characterizes many of these communities, and the diversity of the people who live in rural and frontier areas. From the standpoint of health and health disparities in rural areas, we are concerned about higher rates of mortality due to the leading causes of death, lower insurance coverage rates, higher poverty and increased age, the worsening health provider shortages, and the increased number of hospital closures. In the era of COVID-19, there is a dual disparity for people of color living in rural and frontier areas. As this audience well knows, the population health impact of COVID-19 has exposed in plain sight decades, if not centuries, of inequities that have systematically undermined the physical, social, material, and emotional health of communities, particularly some racial and ethnic minority populations and other groups. Persistent health disparities combined with historic housing patterns, work circumstances, and other factors have put members of some racial and ethnic minority populations at higher risk for COVID-19 infection, for severe illness, and even death. The COVID-19 pandemic has caused a national awakening to both the root causes of health disparities and the fundamental changes that are necessary to achieve health equity. While CDC and its sister federal agencies have long championed efforts to advance health equity, there is a new focus on developing equitable recovery and resilience in communities across America. Today, I hope to gain new knowledge that we can use to inform the CDC COVID-19 response, and also specific strategies that can be deployed to improve health outcomes in rural and frontier areas. So thank you again to our speakers, to the planning committee, and to all of our participants for your presence today. And let's move forward with today's agenda. Thank you.
Well, thank you, Leandris. Thank you, Dr. Liburd. This is Dr. Ian Schuchat with a welcome from the CDC leadership team. I am so grateful to be part of today's session. And I just want to emphasize how important the Public Health Ethics Forum is to our public health community and to us at CDC, and how grateful we are for the partnership with Tuskegee University in hosting this annual forum. Public health ethics is always timely and perhaps never so much as today. While the entire world is facing the COVID pandemic and the western coast of the United States is facing unprecedented forest fires, leaving many rural populations, requiring evacuation in the middle of the night. I think we've never perhaps been in as fragile a state as we are. And as Dr. Liburd just reviewed, the stakes are so high right now in rural communities around the country. Scarcity or disproportionate resources is a theme throughout ethics. And the pandemic highlights whether it's the testing capacity, the contact tracing capacity, the healthcare resources needed for treating urgent and severe illnesses, or the future vaccines that we hope will become available. We know that there are vulnerable communities around the country and that those living in rural areas have particular challenges. The ability for us to be connecting today through this Zoom platform is precious, something we wouldn't have been able to do 10 or 20 years ago, and something that we hope will be available to rural populations and caregivers throughout the nation, but it's not yet there. And I know that many of our speakers today are working in communities that don't have the same kind of communication or technology access that people have in more urban or suburban, peri-urban settings. So I'm looking forward to today's discussions, to learning, and to being able to apply at the national, state, local, and community level the way forward for these public health ethical dilemmas that are never really as real as they are today. Thank you.
Good morning. I'm Rueben Warren, and I too want to do a couple of things. First, to pause about 9/11. And there's not remember, but reflect and how to move forward collectively. Secondly, I want to highlight these, what they're calling unprecedented times. I would suggest they're unusual times, which is a more normal ethical frame on which to view where we are, where we've been, and where we're going. In 2015, the National Center for Bioethics and Research in Healthcare at Tuskegee University joined in partnership with the Office of Minority Health and Health Disparities at CDC to really honor and recognize the 100th year of the death of President Booker T. Washington, the first president of Tuskegee University. We did that to help the nation understand that the whole issues around minority health didn't start in 1905. It started in 2020, nope. It started in 1915 when Booker T. Washington founded Negro Health Week. He recognized the disproportionate burden of health disparities of now impacting on African Americans in particular.
Turn on your video.
Send a message to him saying that he can.
Hello. You're good.
Rueben, Dr. Warren, are you still there, sir? Dr. Warren? I think he's off. So, okay. I think we lost Dr. Warren, and we apologize about that, and hopefully he can get back on. We'll give it just a second, and if he's not able to, then we will continue on with the forum. Okay, hopefully he'll be able to join us here in a few minutes. So I want to thank Dr. Liburd again and Dr. Schuchat for their opening remarks. So I'd like to introduce for our first presenter for this year's forum is Dr. Alana Knudson. Dr. Knudson currently serves as a program area director and as the director of the Walsh Center for Rural Health Analysis at NORC. Dr. Knudson has 20 years of experience leading health services and health policy research projects and implementing and evaluating the impact of public health programs. She has conducted numerous health services and health policy studies and public health projects funded by the Agency for Healthcare Research and Quality, the CDC and the Centers for Medicare and Medicaid Services. Also includes the U.S. Agency for International Development and the Robert Woods Johnson Foundation. Her project findings have informed state, tribal, and federal health policy. Please join me in welcoming Dr. Knudson.
Thank you so much. I will start my slides. There we go. Thank you. I'm absolutely delighted to be with you today. As a person who grew up in a frontier county, I grew up in a county that had 3 people per square mile. So rural public health has been my passion from day one. And I'm delighted to have this opportunity to share some insights with you and hopefully get some questions that can be answered throughout my presentation at the end, as well as later in the day to help advance your work in addressing rural health equity. I am the director of the Walsh Center for Rural Health Analysis, and we are soon to be celebrating our 25th anniversary. The Walsh Center was brought to NORC in 2003. And by the way, NORC has also a long history of rural health research. Our first study was conducted 68 years ago. So rural health has also been an important component of the work that we do in looking at how to advance health and well-being in rural America. As mentioned, we do a number of projects for federal agencies and foundations, as well as serving as one of the 7 rural health research centers funded by the Federal Office of Rural Health Policy. Our center is housed at NORC at the University of Chicago, and we are a nonprofit research organization, and we conduct research and evaluation that serves the public interest and improves the opportunities to make informed decisions. So with that, I just wanted to start with an overall discussion about what is rural. Rural means different things to different people. And I just want to remind you that every single day you are touched by rural America. You eat food, you use energy, you are in a building that often has some kind of materials that are manufactured or produced in rural communities. And I think it's really important to think about rural as part of that interdependence that we have between rural and urban. We have more success in our overall country when we have success in our rural communities and when we have success in our urban communities. And that success starts with healthy populations. To provide a little bit of background on rural, there are many definitions of rural. In fact, the federal government has over 70 definitions. And the 4 definitions that I have included on this slide are the most common definitions that you see that are provided by the US Census Bureau, by the Office of Management Budget, by CDC's National Center for Health Statistics, and by the United States Department of Agriculture's Economic Research Service. These definitions are built on different types of geographic units, which then comprise a different percentage of the population or categorize a different percent of the population as being rural. And the most comprehensive rural population is the definition that is used by the US Census Bureau. And that captures almost 1 out of every 5 Americans, almost 20% are categorized as rural, living in rural communities. The other populations that are included in rural under OMHHE, NCHS, and USDA capture somewhere between 15 and 16% of the population. And these definitions are built on different types of geographic units. They can be zip codes, they can be counties, and they can be census tracts. So when you're looking at one definition, you really need to know what underlies that geographic unit to be able to make comparisons across time and across different populations. This particular slide shows OMHHE, and again, that is the definition that's most comprehensive. And as you can see, the orange darkened counties represent metro, and the gray represent non-metro. And for those of us that have spent our careers working in rural, we would much rather see metro versus rural than metro versus non-metro. But what this does depict is where we have concentrations of urban areas. And as you can see, the gray is most prominent in the Great Plains and in the West. However, there are still a number of rural areas that are interdispersed in some of our most densely populated areas in the country. We also have differences with regard to the distribution of race and ethnicity in rural America. Racial and ethnic minorities comprise about 22% of the rural population. as compared to about 42% of the metro areas. And the largest represented populations are Black and Hispanic. There are also American Indian populations and Alaska Native, as well as other population groups that represent a somewhat smaller demographic. As was mentioned in the introduction to this forum, rural America has some health disparities, and we have been working on these. However, rural Americans continue to be at greater risk of death for the 5 leading causes of death. So no matter what you look at with regard to rural health outcomes, particularly in mortality, you will see higher mortality rates for rural residents than you see for urban. And there are a number of contributing factors. CDC produced this information to share that only 1 in 4 rural adults practice at least 4 of the 5 health-related behaviors that we know would improve health outcomes. And smoking and tobacco use has been a long-standing challenge in many of our rural communities. Likewise, we have much higher BMIs in our rural communities. And there are also some areas in rural America that have very high rates of binge drinking, in addition to not getting enough sleep. For a lot of rural communities, there's a lot of anxiety and a lot of challenge with regard to the economics that people are experiencing, particularly during these unusual times. If we look at some of the underlying issues that contribute to those health disparities, we always rely on our social determinants of health, and this is particularly important when we look at our rural communities. By far, economic stability is part and parcel to some of the health disparities that we see, and that also create barriers for us to be able to achieve health equity in rural communities. I'll share some additional information with regard to poverty, employment, and unemployment in some subsequent slides. Rural residents also do not achieve as high of educational attainment as their urban counterparts, and then this also contributes to long-term earning capacity. Likewise, there is a difference in social and community context in terms of cohesion. Perceptions of discrimination and equity are very important to consider when you're looking at working in rural communities. Likewise, as was mentioned, there are some real challenges with regard to access to health and healthcare. Public health is not as prevalent in many of our rural communities, and there is also less access to health care, primary care, and specialty care. There is also a number of areas that have no access to behavioral health and very limited access at best to oral health. So there are a number of challenges in accessing the health supports that also contribute to overall health and well-being. Lastly, there are some interesting challenges with regard to neighborhood and built environments, including access to healthy foods. And in fact, as a person who grew up in a rural community, I had never been to a farmer's market until I moved to a metropolitan area. And so even the concept of farmers markets has not been as prevalent in rural communities as it has been in urban. Likewise, there's also a challenge in many rural communities of quality of housing and affordable housing, even including in some of our research, affordable utilities. That can also be cost prohibitive. There's also a number of environmental concerns, and I have been to rural communities, in particular a tribal community in my past, where there have been some challenges even in getting drinking water. When you turn on the faucet, the water is brown. So we still have some way to go in even improving some of the drinking water that is available in our rural communities. But by far, one of the most challenging issues that we've had in rural communities is access to employment. and livable wages. And as you can see from this particular slide, when we had that Great Recession from 2007 to 2009, this slide shows that rural and urban were pretty much on par with regard to where we were at the beginning of that time, if you look at where employment was. As you can see, over time, the metropolitan or the urban areas have recovered from that time of the Great Recession, but employment in our rural areas has never recovered. And in fact, we have continued to see that our rural areas have experienced higher unemployment rates than our urban areas consistently since 2007. The only difference was with this last COVID-19 experience, where we see our urban areas having a higher percentage of unemployment than our rural. But this is definitely an anomaly in the unemployment among rural and urban. This also contributes to poverty. And as you can see, the blue represents rural, and the yellow-orange represents metropolitan or urban. And there was a great disparity, obviously in the late 50s between rural and urban. But the challenge is, even though we have seen improvements in decreases in the percent of people living in poverty, rural has never been able to achieve the lower rates of poverty that we see in urban areas. So again, we continue to see that there is long-standing differences in poverty between rural and urban. This issue of poverty is further exacerbated when we look at areas that have had persistent poverty. And these are areas that have had poverty for over 40 years. And if you look at the darkest red counties, those represent rural. And you can see across the country, we also have dual disparities. Although we have poverty in Appalachia, as you can see in Central Appalachia, you can see that the poverty in our southern states remains high. And those are the counties that have the highest proportion of Black residents living in the rural South. Likewise, if you look along the border in Texas and Arizona, those counties also have the highest proportion of Hispanic residents living there. Likewise, when you move to the west and the northern plains, those areas that are darkest are where American Indian reservations are located. Likewise in Alaska, where Alaska Natives live. So there is a great dual disparity when you look between where people of color live and when you overlay it with those rural communities where they reside. So that brings us then to health equity. What are we talking about when we're talking about health equity? I draw from our colleagues at the Robert Wood Johnson Foundation in sharing this definition. Everyone has a fair and just opportunity to be as healthy as possible. And in order to do so, we need to remove economic and social obstacles to health, particularly poverty and discrimination. And when we talk about health equity, what we also talk about is reducing and eliminating health disparities. And sometimes the two get intermixed, but really health disparities serve as the metric for assessing our progress toward health equity. And as I shared in my previous slides, you can see that we still have a long way to go to achieve health equity in our rural communities. I wanted to share with you some ethical considerations to achieving rural health equity that may be new to you, and it may resonate with some of you who already practice in our rural communities. First of all, it's the value of place. Place is very important. Place provides a context of where you live. It is an issue of great pride for many rural areas. There's some very rich history, and in some places there's some very painful history. In some areas we have families that have lived there for generations, and in other places we have people who are just now moving there because COVID has opened up the opportunity to work remotely. And we are hearing more about rural communities welcoming people from urban areas who are looking for a different way of life during this COVID and hopefully post-COVID time. We also have a value of community, and community can mean so many different things. You know, often we say you've been to one rural community, you have seen one rural community. And I think what's also important to understand is that there are networks within all communities. We have networks of churches. We have networks of seniors, citizen centers, for example. We have sport boosters in rural communities. We have civic organizations. We have other community organizations that are connected. So you have all of these different networks that contribute to the vibrancy of our rural communities. But that also contributes to many dual relationships. And in doing so, that means that for those of us who work in public health, there's often a lot of overlap between our personal and our professional connections. And that can create some challenges. There can be some ethical issues arising because a relationship with a stranger is very different than a relationship with somebody that you see in your workplace, as in public health, versus that person that you may see in the grocery store, that you may see at your children's sporting events, and that you may go to church with on Sunday. So there's a different sense of connectedness, and sometimes it can be ethically challenging when you have information, particularly recognizing that stigma can still be a barrier to people getting the support that they need, in particular for substance use disorders, as well as domestic violence. Those types of issues are sometimes very difficult to navigate in rural communities because there is this sense that people know your business. And when I used to work at the North Dakota Department of Health, the #1 question that was never answered in our behavioral risk factor surveillance system survey was a question on finances. So even that issue about finances can be seen as something very personal, and it contributes to some of that autonomy that a lot of rural community members feel. They feel very independent, and they are very concerned about other people having more information about their family, or perhaps having a different view of them because the community is small. It also affects organizational level decision-making as well as state and national level decision-making. And one of the areas that I think that has been most challenging looking at rural public health is the allocation of resources. And this is something that we are always challenged with, because oftentimes if we have a public health intervention, we want to reach as many people as possible. However, if we are really going to advance health equity, we may need to reach to a smaller subpopulation that may have fewer people, but have greater needs. And sometimes it is difficult to advocate for using those resources to reach smaller populations with policymakers or other decision makers when the pressure or the accountability for that funding is to reach as many people as possible. So there are sometimes challenges in that arena as well. And so when you're thinking about the ethics that really underlie what you're doing, I would really encourage you to think of a values approach, because values are really central to what is framed as ethics. And really coming together and identifying what is the value of the community can also help provide some really important guiding principles. And frankly, there aren't that many rural ethicists out there, particularly rural public health ethicists. And so I think this is also an opportunity through this forum to bring together people who are interested in this area and perhaps create a network of public health colleagues who can come together and talk about these very unique and very important issues that really have consequences for the health and well-being of rural communities, and ultimately the opportunity for us to achieve real rural health equity. And in doing so, it is also very important to think about that rural context, because again, plugging and playing rural and urban does not work. We have seen that in many examples in the past. Trying to transplant a program that worked well in a resource-rich urban environment does not necessarily work well in a rural environment. So I'm going to share a visual that we developed as part of a Robert Wood Johnson Foundation project, in which we looked at the strengths and assets of rural communities. And I think, again, that is another really important perspective when you're thinking about achieving health equity. Look at the different types of strengths and assets that come together that create our rural communities and our networks within rural communities, because they're very important to the vitality of that community. And it also helps to bring people around a table to look at what is working well. For any of you who have ever sat on the other side of the table, and I have done that, it's really a challenge to have someone come and tell you all the things that are bad in your community. But when you can come around the table and say, look at all the positive things that we have going for us, and look at where we want to get to be able to achieve even more for our community members, having a context and having a way to talk about strengths and assets is a value add that not only can improve health, but it can improve the entire community in terms of looking at economic development, in improving education, improving health and safety. All these different areas can greatly benefit from looking at strengths and assets. One of the things that I think public health has a very unique and important role in doing and contributing to their rural community is serving as a convener. I cannot tell you how many times I have interviewed different types of successful networks, coalitions, organizations that have said public health was really the catalyst that brought us all together. And if we are really going to be ethical in our work at advancing rural health equity, we need to bring all stakeholders to the table. And that also includes some of our communities that are marginalized and some residents that don't always have a voice. And sometimes that means that we're going to have to nurture and grow and build trust relationships so that those community members can feel that they have a voice and that they are part of the decision-making that goes into identifying how to address health disparities and how to look at improving social determinants of health, and ultimately how to achieve health access or health equity. And so whenever we talk in rural communities, and I know the Surgeon General has had a real focus on looking at how that link between health and wealth can improve health outcomes, not only at the individual and family level, but at the community and at the state and national level. It's important and foundational to improve the economic well-being of people to be able to improve their overall health and to achieve health equity. And so I want to make sure that you have some tools that you can draw upon, especially if you are new to working in rural communities, or if you have some interest in starting to address some social determinants, to address health disparities, to further your achievement of health equity. In partnership with the Rural Health Information Hub, which is funded by the Federal Office of Rural Health Policy, our NORC Walsh Center, in partnership also with the University of Minnesota's Rural Health Research Center, have developed over 24 toolkits that address different issues that affect the health and well-being of rural communities. And all of these toolkits are developed in a modular format so that no matter where you are, either at the very beginning at identifying an issue that you want to further pursue for addressing health and well-being, or if you are already in play and you want information on how you can evaluate a program that is part of your community at this time, there are different ways that you can just plug right into these toolkits to be able to get additional information. One of the things that we include in each of these toolkits are program models. And these are models that have been tried, tested, and successful in rural communities. And again, this is not about plugging and playing a rural model and trying to retrofit it into an urban area. It is really about looking at what is successful given rural context, given rural resources, and also given rural values. And we also have a program clearinghouse that has specific programs that are successful with not only the overview of those programs, but also a contact, because we know rural people like to talk to other rural people. So it provides an opportunity to talk directly to that program implementer, as well as finding out information pertaining to implementation, evaluation, sustainability, and how to share the great good work that you're doing. There are also some really important considerations, for example, on how to create networks and coalitions, and how to engage your rural community in the particular issue that you are trying to address. In addition to the social determinants of health toolkit, we have a number of other toolkits that may be particularly helpful in addressing social determinants of health. I have never been to a meeting in a rural community where transportation wasn't identified as either the first or second challenge that a rural community has in being able to access health and other services that support health and well-being. And again, all of these toolkits are available on the Rural Health Information Hub. The website is ruralhealthinfo.org. This particular hub has also access to information specialists, which you can contact by phone or by email. And usually within 24 hours, you will receive a response. So if you are interested in a specific topic, or if you are interested in finding information about how to fund something, or where there might be a program that you are interested in implementing, you can contact the Resource and Referral Center, and they will make that, provide that connection for you. And please know all these services are free. Again, it is sponsored by the Federal Office of Rural Health Policy, which is located in the Health Services and Resources Administration. And they also work very closely with all of your colleagues at CDC. And if you have information that you would like to share, there's also a section to share successes. So we are always looking for ways to help disseminate the incredible work and innovation that is occurring in our rural communities. So with that, if you have any questions, I'd be happy to take them now, or if you think of them at a later time, please contact me.
Okay, thank you so much, Dr. Knudson, for that very informative presentation. We do have a time for just a few questions.
One of the questions is, what do COVID rates look like in rural communities? And is the COVID mortality rate higher in rural communities? Well, unfortunately, my home state of North Dakota has the highest rate at this point. Some of our rural communities have had COVID rates that are high. Mortality is, similar to across the country. It is somewhat higher for those with multiple chronic conditions or in nursing homes that are challenged with health issues. But rural is not immune to COVID, and we have seen some high rates of COVID in areas where there have been large like manufacturing or production plants, like in pork plants or other types of value add agriculture. And so COVID is something that needs to be continually monitored in rural. I will say there are much fewer epidemiologists that are working in rural, and oftentimes rural areas rely also on the state and having coverage for epidemiologists to help with the contact tracing and follow-up in those counties. There are a couple of questions about, are there any programs that are specifically addressing the persistent poverty in certain counties throughout the South, Texas, and the West, as depicted in red on one of the slides. And there are some programs that are targeted. If you recall, in Appalachia, the Appalachian Regional Commission has had some success in reducing some of the persistent poverty counties. They have had funding to do so. The funding, for example, in the Delta region has not been robust, and so there hasn't been quite as much investment in those counties, but clearly there are a number of opportunities to make a difference.
Okay. Well, thank you again, Dr. Knudson, for your participation in our forum today and for your presentation. Okay, right, we're going to turn it now. Now I want to reintroduce Dr. Warren. Dr. Warren, apologize earlier. I know I'm having some technical difficulties, and so if you want, would like for you to take a few seconds to finish your remarks, and then you could go right into our panel discussion for today's forum. Thank you.
Thank you again, and I'm back on. And we have to deal with this as we deal with other kinds of adjustments. I won't take any more of your time in my introductory remarks, except simply to, as I reflected on Dr. Knudson's comments, certain things came to mind. And the most important from my context is the rural populations moving to urban areas and that adjustment. She mentioned people and places. And what we found is that people bring their culture to the new place. And so in Chicago, in Washington, D.C., in Los Angeles, California, there are rural populations, African Americans in particular, that brought that culture right to the city. And we have to recognize that people bring their culture to the new place. And I close that out with my reflections on the Great Migration, 1920 to the 1950s, when African Americans moved from the rural South into the North, looking for new and different opportunities to really respond to what we now recognize clearly, institutional racism. Let me close those remarks to move on to what I think is a very exciting panel of speakers that's going to talk about rural health and the perspective on public health ethics. And what I won't do is belabor the time by introducing all of them and giving you their backgrounds. You can read them. And what I want to do is follow the line as they're listed and have them answer a couple of questions. And we want to at least leave some time for hopefully some question and answers as we end this panel. Let me also say this panel's over the years have been exciting. Our first one dealt with women's health, and then we moved on to talk about the elderly. And our last and most exciting for me was the one dealing with youth. And so we're really having some exciting times talking about the opportunities from a full panel discussion. And so I'll start with just calling the names of our panelists, and then we'll move on to the questions.